Healthcareonomics, changing healthcare by changing the way you think about healthcare. Hi everybody, welcome to Healthcareonomics. I'm your host, Dr. Kevin Wacasey, and today's episode of Healthcareonomics for Patients is episode number 7. And I have with me today my guest, Dr. Devon Herrick. Devon is a health economist who got his Ph.D. in, policy economics? Is that correct, Devon?
Economy.
Political economy, who got his Ph.D. in political economy, but before that he was a hospital accountant and got to know the ins and outs of all the hospital wherewithal and the backroom stuff before he went to work for the National Center for Policy Analysis in Dallas, Texas, for about 12 years, if I'm correct, until that organization closed in July of 2017. Then since that time, he has been a policy advisor for the Heartland Institute. And Dr. Herrick also does some freelance work on the side for my favorite kind of think tank and policy organizations, free market policy organizations and think tanks. So I want to thank you very much, Dr. Herrick, for coming on the show today.
Well, thanks for having me.
I appreciate your time. Now, I have to tell this story, and we're going to cut to a quick video clip here, where I first ran across you, so to speak. And this was in way back in 2013. I was watching the news, which doesn't happen very often, I must admit, but I was watching the local news here in the Dallas-Fort Worth area, and I saw a story about a woman who had been ripped off by a freestanding emergency room. We have these things in Texas here, and due to her high deductible, she had been severely overcharged for a cough, for a bronchitis visit to one of these freestanding emergency rooms, and they were showcasing her case, and Dr. Herrick was a guest on that show and had a little blurb, and I'll just show you exactly what I'm talking about right here.
Devon Herrick is a health economist for the National Center for Policy Analysis.
That's precisely the reason that consumers and patients need to be aware of the difference.
So if you notice, the thing that I really got struck by was that Dr. Herrick used the terms consumer and patient in the same sentence. And that really turned me on to, hey, this guy, he really is something to stick out there, because my experience with health economists, as we'll talk about later, has been that in general, they either don't know what the heck they're talking about, or to me, to not sound too conspiratorial, they're, in my opinion, bought off or working for an industry that they're supposed to be analyzing. So that being said, Dr. Herrick, why don't you take it away and tell us a little bit about yourself and tell us about what exactly it is you do.
Well, as you said, I'm a health economist, and what that means is I'm an economist and I apply my craft to healthcare. And as you well know, healthcare is the most convoluted economic system we have. In all other areas of our economy, our suppliers and producers compete on price and quality and other amenities, and transparency is the norm. I mean, obviously, some areas more than others.
Right.
In healthcare, price is very hard to find, and when you do find the price, there's not one price. There's maybe dozens of prices, depending on who you are and whose health plan, who you work for, whose health plan you're involved in, and it's as you well know from my Twitter feed, we have people we've never met have the ability to send us bills for anywhere from a multiple of, I want to say the market price. We don't really know what the market price is, because you have to have a market, you have to have a clearing market to find that out. So in a sense, if you're an economist, the area that it's maybe the most fascinating would be healthcare. It's also the most annoying, because the healthcare economy really does not work like any other economy, and it does not work at all, as you well know.
Yeah, right. Yeah, this is, okay, not to get too far into bashing people too soon, but I have a Twitter account, as you well know, and that's where we got back together a couple of years ago, was following each other on Twitter. And one of the most fascinating exchanges I've ever had was with a so-called self-described health economist. I'll put the tweet up right now, the series of tweets, where he was arguing with me about, one of my most famous tweets is about the cost of an EKG. Now, the marginal cost for me to do an EKG is around 60 cents, say 70 cents. The price is going up. And that's for the 10 pieces of plastic and the single sheet of paper that I use to do an EKG. Now, that doesn't include the cost of the machine, doesn't include the cost of rent and utilities and paying salaries and all this other stuff. But those are fixed operating costs. My marginal cost for building or for doing an EKG is around 60 cents. When I tweet this out, when I put this out there, I get all kinds of people telling me I don't know what in the heck I'm talking about, which, is true in a lot of sense because I've never taken one course in business. But I happened to ask this clown who was dogging me about this one time, this so-called health economist. I said, look, how much does an EKG actually cost? And he said, well, what are you talking about? The charge master price versus this? And he said, in our, if I remember correctly, he said that in our system that he works with, our cost is anywhere from $300 to $1,800. I think he said in his tweet. It's up on the screen, should be. And I was blown away by that. I said, no, Ace, what does an EKG really cost? He couldn't answer me the question. He had no clue, no idea. And to me, that's what gives really an air of illegitimacy, if you will, to an entire field of so-called health economics, not including you, sir. Because if you don't know what the thing costs that you're evaluating and analyzing and studying and researching and publishing on, then what in the hell are you talking about? And so I really applaud your efforts. You've done a lot to stand up against this, to stand up against what I call the great American healthcare fiasco. And that's the idea that, healthcare is so overpriced and so expensive, not overpriced, but so expensive that we need health insurance to cover it. Anyway, I'll quit rambling and let you get back to telling us, what is it in your mind that a health economist should be doing? What is it that you strive to do?
Well, what I strive to do, as you know, is I try to get the consumer more involved in their healthcare decisions. Right. And I do this because I know that having third parties make all the decisions for us, in fact, leads to a lot of, welfare loss.
Yeah. And
one of the things that you mentioned, or that you alluded to, is, it also leads to a loss of competition. Right. I mean, your discussion on EKG is precisely accurate. I mean, you know that you have the machine. You know what that machine costs you. You have a basic idea of how much maintenance that machine needs. You know what your office rent is. You know what your utilities are. And you correctly identify the only variable cost of running that, aside from your time, is the cost of the consumables,
right.
The film. Correct. So if you were going to compete on price and quality and other amenities with another healthcare organization, you would say, okay, here's my rent. Here's I can do 1,000 of these a week.
Right.
Okay, here's my rent for the week. Here's my income for the week. Here's what my competitors are charging. That's how competition works. You figure out what your cost structure is. You figure out what you can do it for. You offer a deal and you do your best to attract customers. Well, right. That's very foreign in healthcare. No one, or I shouldn't say nobody, you're doing it.
Right.
And there are a lot of other physicians doing that, but it's not the norm.
No, it's not. It's not, unfortunately. And I like to say that all those fixed operating costs, the cost of running a business, the cost of having salaries, of paying insurance, paying for the EKG machine and its maintenance, etc., all of those things factor into what I charge for that EKG. They have to. I have to consider those as aspects of what I charge for the EKG, but through a very clever sleight of hand or sleight of word trick, let's say, as I detail in my first book, The Guide to Buying Health Insurance and Healthcare, a very clever sleight of words has occurred over the past 40 or 50 years, and that is the rising cost of healthcare. This notion that healthcare is costly inherently, and it's not. It's really not. In fact, what I love to do, and please correct me if I'm wrong here. You're an economist, so you tell me if I'm wrong on this or not. But when people counter me with this whole EKG idea about it can't possibly cost you 60 cents, what are you talking about? You've got all this stuff. If I were to ask these same people how much it costs to build you're from Texas, Devon, so a Whataburger, let's say, Whataburger with cheese. How much does it cost to build a Whopper with a Whataburger with cheese? I guarantee you, these same people would say, well, you got the buns, you got the meat, you got the cheese, you got the vegetables if you want them, and I don't know, throw in a little ketchup, mustard, mayo, whatever your favorite is, and that's it. They wouldn't start going into, the cost of the cook the salary of the cook, the cost of the equipment to bake and cook these things on, the parking lot maintenance cost. They wouldn't go into all that. But when it comes to healthcare, it's so easy for even health economists to get into this notion that, oh, healthcare is just so outrageously expensive. And I think part of that is intentional. And I would ask your opinion on this. I think a big part of this is intentional on even the part of so-called health economists as nothing more to either, and that stems from either an ignorance on their part, which I wouldn't doubt, or the more sinister part of me, the more paranoid part of me, tends to think that maybe they're being paid by certain industries to say these types of things. What say you?
Well, before you even finished your anecdote, I was thinking in my head that what a lot of them do is they think, well, you're not including the cost of caring for those patients that can't pay for their own care, or they're not paying. They're not anticipating. Well, you've heard this all before. It's like we're required by the Affordable Care Act to pay many times our expected cost, so that those people that maybe haven't gone to the doctor and seen you in 20 years can suddenly realize they're late middle-aged and maybe they should go to the doctor.
Right.
And maybe they have unmet needs from many years ago. That's the whole pre-existing condition argument and discussion. But I mean, what you're talking about, whether it's your EKG or whether it's building a Whataburger, it's fixed and variable cost. I mean, you can get technical and get into step cost. I mean,
sure.
If you're not building Whataburgers, you wouldn't need to have the employees there. But I can guarantee you that Whataburger and any fast food purveyor of fast food has a really, really good idea of what their fixed and variable costs are, because their margins are probably only 3 or 4 or 5%.
Sure, that's right.
And in healthcare, I spoke to a Rotary Club a few weeks ago, and if you speak to groups very often, you're always in the back of your mind is, who am I going to offend? Not that I'm going to change what I say, but there's always someone I'm going to offend.
Sure.
I haven't had that trouble, believe it or not. But I met a former retired hospital executive, and she literally said to me, "We have no idea what anything costs." Right. I was very surprised that she was that candid.
Yeah.
But and I've had other, hospital administrators tell me, like I did a talk to a different Rotary group. And I had a man coming up to me afterwards and say, I'm a hospital administrator. I agree with you 100%. We do our best to let our customers, our patients know what things are going to cost, because we don't want them to have surprise medical bills.
Wow.
The more we tell them, the happier they are. And I was amazed he too was agreeing with what I had to say.
Yeah.
And I get a lot. I mean, it's amazing how many people in healthcare will agree with what I have to say, what you have to say, but why doesn't that translate into the bigger picture, which is maybe healthcare really is a consumer good to some degree, and why can't patients working with their doctors, have mutually agreed upon services, prices, the normal market stuff.
Well, part of the problem with that is that when you talk about healthcare, from policy experts to pundits to politicians, everybody that talks about healthcare tends to focus on truly catastrophic healthcare. I'm not talking about health insurance. I'm talking about health care. And they focus on this idea of waking up in an emergency room with various tubes stuck in various parts of your body. Or they talk about the catastrophic cancer diagnosis, these types of things. But really, when it boils down to, and I go over this in my first book, where I talk about this in detail, the vast majority, I would say probably, and there's no way to put a percentage on this, okay? But I would say, ballpark figure, 70 to 80% of health care is not catastrophic. It is not, and by catastrophic, what I mean is it's not catastrophic in nature as in it's going to be something that's going to take a lot to treat, a lot to do. In other words, most of health care is either routine and predictable, like primary care, which is what I do these days, or even if it's not routine and predictable, even something like a gallbladder operation. That's something that in most cases is an elective procedure. The vast majority of gallbladders that are removed in the United States, the hundreds of thousands of gallbladders a year that are removed, I'm guessing on that statistic, by the way, the vast majority of those are elective procedures. And what that means is they're planned. You have time to plan them. And if you have time to plan them, then you have time to price them. You ought to be able to anyway. And what this really boils down to is that healthcare is not, the vast majority of healthcare is not some emergency that's waiting to strike you like lightning. The vast majority of healthcare is either routine and predictable, or it is something that if you save up a little bit, most people can save up to buy a car. Most people will spend, there are people who think that spending $42,000 on a truck is absolutely cool. But yet spending, $15,000 on a knee replacement, what are we going to do? Oh my gosh, this is absurd. And we need to change our view of health care and the cost of health care and how we pay for it in this country, or else we're headed down a rabbit hole we'll never get out of. I think you'd agree with me on that.
Well, yeah, that's absolutely true. I mean, you probably don't know this, but one of the areas of research that I've worked on over the years that I find the most interesting as a health economist is cosmetic surgery and cosmetic services. And, your natural response is, well, why? That has nothing to do with real healthcare. Well, it kind of does. It's a lot of the same doctors, a lot of the same clinics, a lot of physicians who do what I would call curative medicine also dabble or have sidelines in cosmetic services. And what's fascinating is their whole operating system changes. Their business model changes.
Right.
In one area, where curative medicine, I'll call it, it's very bureaucratic. They rely on insurance. They have a big billing staff. The other part of their practice, it's streamlined.
This week on special.
I mean, I used to collect Groupon advertisements for medical services, just as anecdotes.
Yeah.
You're not apt to die. I've had people tell me. In fact, I've given my spiel on Capitol Hill at a briefing, and I had a senior aide for one of the leadership in the Democratic leadership say, just wave her hands and just say, that doesn't count. That's not real. It's not real medicine. It is real medicine. It's real doctors. It's real operating rooms. I use it as an example of if I can get a facelift or breast augmentation or what have you, that's competitive.
Yeah.
I mean, I should add that I have 24 years worth of pricing data for surgeons' fees. Guess what? They're very stable. They have risen in price equal to consumer inflation. As you know, medical inflation is about 3 times consumer inflation.
Right.
And
if you can even get a handle on it. Yeah, go ahead.
Yeah, and for those services that are what are called minimally invasive, Botox, for example,
sure.
Those have risen because the physician that owns the practice can train nurse practitioners or estheticians to do those services. Those have gone up in price only about 2/3 of consumer inflation because it's competition.
Yeah, why is that? Yeah, why don't you get into what's the secret behind that? Yeah.
Yeah, it's exactly if physicians can compete on price, quality, and other amenities in this one medical marketplace, imagine what they could do in all the other areas of medicine if they had incentives. And by incentives, I mean if you didn't have third-party payment that covers 90% of all of our health care. I mean, let's say we had a system like Singapore where there is I think it's called MediShield. It's kind of like a grand catastrophic plan. Right. And then you have MediSave, which is you're going to put money in a MediSave account, think health savings account.
Sure.
And you're going to do it whether you like it or not. It's not optional. It is mandatory, like Social Security, but it's your money. It's not going off to avoid toward the national debt. It's going into an account that you control, like a health savings account. Can you imagine what people would do if the majority of healthcare they're paying for, the day-to-day healthcare,
Sure.
came out of that account? I bet they'd be consumers, and that doctors, not maybe not hospitals, that's a different story, but physicians and most of your day-to-day healthcare, you would act like competitors.
Sure.
Because you'd want that customer in the door as opposed to the office down the hall.
Right. What I like to say is the doctors would be competing for the patient's care instead of for Aetna contracts and Cigna contracts, United Healthcare contracts. The doctors would be competing on an individual. Hey, look at me! I'm better. I offer this, and our waiting room has a waterfall in it or a hot tub. There was a dentist that had a hot tub in his waiting room around here somewhere. Crazy like that. So, those kinds of gimmicks, those kinds of gags, but in reducing price, reducing cost is the number one gimmick. It's the number one gag to use when increasing your competitive nature and attracting customers. That doesn't happen these days.
Yeah, I had a marketing professor many years ago when I was working on an MBA that said, price isn't the only consideration, but it is always a consideration.
Yeah.
And if you're like, I had to look for a CT scan several years back. I've used this anecdote a million times. And, well, I didn't, but inadvertently, someone I know went to a large hospital system, the one I used to work for, but I won't name names.
Right.
Guess what? It was like $3,000. I forget the exact price. And I said, well, why would you go to a hospital if you can walk? If you're ambulatory, you never go to a hospital for care. If you can,
I'll take my insurance.
if you can go anywhere else. I got on the internet, and 10 minutes later, I found a CT scan, which happened to be a freestanding facility,
Right.
maybe 100 yards from the doctor's office.
Wow.
For $403.
Wow.
And most people don't realize you can do that. And what I can't figure out is how come employers and insurers and health plans don't give us more incentive and more direction to find that. I know you've probably had numerous patients that went to the wrong location to get a service. And you said, well, why'd you go there? I could have got you that for a fraction of that. Because they didn't know, because they had never been taught that this is a consumer good that you have some control over.
Actually, my patients don't experience that. What happened with my patients is rather an interesting take on that. A couple of patients, in my experience, and I wrote about one of them in my book, is they will go to the place where I send them to, but they won't heed my instructions. I will tell them, do not tell them you have health insurance, because you're going to be paying the health insurance rate at that point. And a couple of my patients did actually go over to the facility or to the place where I referred them to, and one of them, I wrote about it in the book, she needed an ultrasound, and she said, well, okay, so how much is it if I just pay cash? And they said, $130. She goes, okay, so how much is it if I use my health insurance? And they go, oh, you have health insurance? Oh, well, it's a $200 copay, and then we'll balance bill the rest of you. And she's like, wait a minute, I want the cash price. And they said, sorry, ma'am, no can do. The cat's out of the bag now. We know you have health insurance. One thing that you're a consumer-oriented, you want to turn patients into consumers. And I agree with that 100%. And in my mind, they already are consumers. If you have a 4 or even a 5-figure deductible on your health insurance plan, you're a consumer. Now act like
we all
it.
are.
Okay?
Yeah, we all have 4 or 5 figures.
Right. Well, there's a few that don't, and I say to them, enjoy that while it lasts. But after that, everybody else needs to just say, hey, listen, I'm a consumer now. I'm going to take these consumer things into my own hands. And I saw not too long ago, I wish I had taken a picture of this, and I'm sure it'll come around again, but I saw in one of my local coupon mailers, the value pack or whatever they mailed to me, I saw a coupon for an oil change for $24.99. Now, I remember back in college, 30-something years ago, oil changes were $20, $25. I remember because I couldn't afford them back in college. I drove my car till it was on fumes with the oil. So why is it that oil has changed? Oil changes haven't really gone up in price. You can still find them what they were decades ago. It's because of competition. Now, here's my question for you, Dr. Herrick. You understand this completely. I understand this completely. The average Joe Schmo consumer on the street understands this completely. Why is it, if you would, why is it that most so-called health economists don't understand this? Or at least they don't write about it. Why is that?
Well, I need to kind of go back to a comment that the president or the CEO of the National Center for Policy Analysis made in a blog post years ago. He said, John Goodman, he said, the average person's IQ falls 10 points when they begin to talk about health policy. And his point was, as you can imagine, is for some reason, otherwise smart people, we assume things about healthcare that in fact we would not assume in other industries for stupid reasons. Like, why is the cost of an oil change? Why has it not gone up? Well, obviously it's because there are more firms willing to do it at lower prices. Maybe you got it done at the gas station 30 years ago, and now there are dedicated places just for that oil change.
And across the street from each other.
Sure. As far as the average health economist, I've told you in the past that, in my opinion, a lot of people that use the title health economist are not really economists at all. I mean, they're not. It's almost got it's like a catchphrase where if you do health policy or health, you claim you're an economist. Well, they're not really economists. They're advocates for public health. Public health advocates tend to think that people that are healthy are happy to pay much higher than otherwise, so that people that are less healthy get a free ride. And advocates assume that we all should pay a lot more at the hospital so that hospitals can cover all those 3-story atriums that are made out of marble and glass. And whereas what you're talking about is providers. There's something like 735,000 practicing physicians in the U.S. Yeah. Imagine if, and I forget how many hospitals there are. I used to know that statistic, but in those hospitals are probably hundreds of thousands of executives or people doing all kinds of stuff. Yeah. What if you had 735,000 practicing physicians and let's say 250,000, million people, 1 million smart people, all trying to find little niches, little places like oil. I mean, obviously, little niches where they can get the costs lower and beat out someone else that's charging more. Well, that's how our economy works in most other areas of our economy. Is you have millions of, I use the word loosely, millions of suppliers, purveyors of services, all looking for incremental advantages. So they just do one thing better than the next guy or the next supplier. And if they can do that, they do it cheaper, they get customers.
That's right.
The ripple effect, across our entire economy over the course of, billions of transactions per year. That's how competition would work, but we don't do it that way. We have, in most cases, we have networks with negotiated prices, but what people don't know is the price negotiated at the hospital is not the same price negotiated down the street at the freestanding place. I mean, something that I think is really interesting is an experiment that the California Public Employees Union, the retiree union or retiree system did a few years ago. They noticed that at hospitals, the cost of a knee replacement and a hip replacement varied from, like $25,000 to $125,000. Just throw numbers out there. I mean, that's not exactly, but that's close with what they found. And that was just the hospital fee. That was not the physician fee. That was not the implant fee. The implant itself. That was just the hospital.
Yeah.
And so, what they did was they were working with their third-party administrator, a big insurance company. They said, you're going to do this experiment. This experiment is we've identified 46 hospitals that will do a joint replacement service for $30,000 or less. So you can go anywhere you want to, but if you go to a hospital that charges more than $30,000, you're paying the difference. And what was funny was within a year, most of their enrollees or their beneficiaries, it was a pension retiree plan, most of the beneficiaries had shifted to the high value hospitals.
So you're saying they became consumers?
Right, exactly.
Ah.
And what that did, within a year of that happening, most of the high-priced hospitals,
Let me guess.
they matched the price.
Of course, they have to.
And they knew that was the case because they had a control group. It was the insurance companies, enrollees from their private plans that were not, retirees.
Wow.
Whereas in the retiree plan, prices fell. In the commercial plan, prices didn't fall.
Wow. Wow. So this was a study. Do you have a link to this that I can put on this website?
It is. I do. I'll have to get it to you. I can get you.
Okay,
it was published in Health Affairs, and they also did at least one other experiment that I know of.
Wow.
And it was, I think, cataract surgery, trying to convince their enrollees to go to ambulatory surgery as opposed to the hospital. Again, using cost sharing. It's what's known as reference pricing. Here's the reference price. The reference price is $30,000.
Right.
Here's a list of 46 hospitals that will do it. They're high-quality hospitals, or not, the bargain basement, but they will do the service for $30,000.
Right.
Go anywhere you want. And they educated, our CalPERS educated, and I think WellPoint ran the experiment. The physicians saying, oh, by the way, if you send one of your patients, if they go to the wrong hospital, they're going to have to pay a whole lot more. They're not going to be happy.
Yeah.
And it didn't affect the surgeon fees. It just affected the hospital fees. And it was an astounding success.
Well, I can tell you that I recently underwent cataract surgery for my left eye here. I'm 50, but it was a long story. I got hit in the eye with a baseball when I was a kid. So I had a cataract in the left eye. I had it repaired or had it replaced. I don't qualify for Medicare to replace that, and my health coverage doesn't cover that at all, the kind of health coverage that I have. So I had to pay out of pocket for it. I shopped around and got a great deal. It was less than $5,000. Now, let me tell you that is a lot of money, but that is less than the price of a crappy used car to fix my vision, folks, for the rest of my life. That's it. So don't tell me that healthcare is outrageously outrageously costly. It's outrageously overpriced. And if you shop around, you can get the best deal. Well, Dr. Herrick, I want to thank you so much for joining me, and I hope this is the first of many appearances for you. I would like to have you back on the show if you'd like to come. You can be my guest anytime, because I like to say that if health economists knew the true costs of healthcare, there would be no need for health economists. But you, sir, are definitely an exception, and I thank you again for coming on.
Well, thanks for having me, and thanks for the kind word.
Appreciate it. All right, folks, so that's it for this episode of Healthcareonomics for Patients. I hope you tune in next time. In the meantime, you can catch us on iTunes, SoundCloud, and on Mike Church's radio channel, crusadechannel.com. Check us out with Mike Church's show. I love Mike. He's a great guy. Please listen and subscribe to crusadechannel.com. And in the meantime, Dr. Herrick, until next time we talk, and everybody else, stay healthy. Now you can easily compare health insurance plans and pick the one that makes the most financial sense with the Dr. W's Equation app, available for Android and iPhone. And for more information on how you can save on health insurance and healthcare, check out my books, available now on Amazon, iTunes, and Nook. To help spread this message, please click the like button on this video. You can also subscribe to the Healthcareonomics YouTube channel and visit healthcareonomics.com.